There were other situations that we tested and talked about at this meeting about molecularly directed therapy that didn't pan out. And I'm thinking specifically about a large phase 3 trial, or at least a medium to large trial called MADE IT, as well as a group trial by the Spanish lung cancer group that looked at molecular markers that are sometimes tested for in trials and sometimes even outside of trials and are used even outside of studies to guide therapy right now. But they didn't look that favorable. Mary, can you tell us a bit about those trials and what you think the implications might be?
Yeah, absolutely. So I'm very familiar with the MADE IT trial, which was presented because that trial was conducted largely at Moffitt. And at the time, it was very exciting. So even looking back, it was exciting that we were taking patients basically newly diagnosed with advanced lung cancer. And then we were testing their tumors in real time and using the information on two proteins called ERCC1 and RRM1, which are involved in response to chemotherapy and DNA repair. And then we were assigning patients to treatments based on the levels of those proteins. And this was based on some earlier work that suggested that those proteins were important in how patients responded to two different types of chemotherapy, platinum compounds and gemcitabine. And so the trial was a randomized trial, and the control group of the trial received carboplatin and gemcitabine. And the experimental group was broken down into 4 groups depending on the levels of those proteins. And then each of those 4 groups received different chemotherapies. And the hypothesis was that the people who got personalized chemotherapy based on the levels of these proteins would do better than the people who just got standard chemotherapy. And unfortunately, that didn't pan out. The groups did the same, really, regardless of whether they got customized chemotherapy or standard chemotherapy. There were some interesting potential reasons for that, and I think this trial was also a cautionary tale for a lot of us in terms of how we do trials, but also for exactly what you said, starting to adopt these markers without being on a trial and using them to make treatment decisions for patients off protocols. So the trial ended up, as I said, being negative. I think there are some important lessons learned, but unfortunately, I think it may mean that this is not going to move forward in terms of using these markers for customizing chemotherapy. And as Dr. Bepler said, I think in response to a question, the field has moved on as well. You know, since that trial was designed, it was very innovative at the time. Since it was designed, now we have all these other molecular markers that we're using to make patient decisions. And so I don't know where it's going to fit in the long run.
And the Spanish lung cancer group had a very similar concept and unfortunately no better result.
Right, and the trial was actually stopped early because one of the experimental arms actually was doing significantly worse and driving down the survival in the customized arm.
From a practical standpoint, was it a problem to have patients randomized to the standard arm rather than the customized arm? I mean, once you heard about the concept behind the trial, was this something where patients were sold on the concept so much that they were very reluctant to participate if they didn't get randomized to the arm that they thought was the right one?
Well, the interesting thing is there's a gemcitabine carboplatin arm on the experimental arm, and there's a gemcitabine carboplatin arm on the control arm, and we were blinded to whether they were experimental or control if they were on that arm. So if they were on one of the other customized arms, you always knew they were on the customized therapy, but if they were on the control arm, you didn't know, and neither did the patient. So that solved a lot of, I think, that. And most patients seem to be excited about having the analysis done on their tissue and participating in this study. So it wasn't much of an issue. I think there were some things that came along in the course of the trial. The trial was designed before Avastin. The trial was designed before Alimta. And so some of these new drugs were coming along towards the end of the trial. And so that made it a little bit more complex.
I think it's an interesting challenge in that we have a lot of examples of early work that looks so promising that even we or lots of people might think they know what the answer is going to be, and that can circumvent or undermine the trial getting completed because people want to do, especially if they can do it outside of a trial, they want to pursue that. And I think this is one cautionary tale, that this is why we need to do the trials, because sometimes the early results are misleading, and we shouldn't just run off and do everything just because there's a commercial approach to it.
Right. I agree. There were also some concerns with actually the assay that was used to do the testing. And so I think that also gave me pause, thinking, you know, there are so many different assays that are used across institutions, and there's a lot of potential for variability there, and being able to really believe our test results is important as well.